So, good afternoon. My name is Bob Cochrane. I'm an account manager with Dementia UK, and I'm joined today by Paul Edwards, who is the Director of Clinical Services. Hi, Paul.
Hi, nice to see you, Bob. Everything okay?
Yes, thank you. Enjoying some sunshine here. So, Paul, for the summer school, I thought it might be useful just to ask you some questions that might just be a little bit more human than you making a presentation, which of course you do very often, and really just to get some kind of measure of what's happening in dementia care in the UK today. Is it okay if I just ask you some questions?
Sure, fire away, Bob. No problem.
Okay, so this is an easy one to start with. Could you paint a picture of what's happening in dementia care across the UK right now?
Wow, yeah, an easy question. As you'll know as well as I do, Bob, that things are pretty complicated in right across the UK, actually, at the moment in terms of dementia care. There are some hopeful things going on. There are some change. There's quite a lot of change going on, actually, in terms of structures and systems. There's also a sort of post-COVID legacy effect still happening. So maybe I'll take all of those things apart a little bit. So one of the things that's happening nationally in England is that last year we spent a lot of time waiting for the new 10-year dementia strategy. Every few years we have a new dementia strategy, and we were waiting and waiting for that. That didn't materialise, but what did materialise this year was the government in England, so the Department of Health and Social Care, wanting to combine a number of different strategies across major conditions. It's called the Major Condition Strategy. So they link together cardiovascular disease, musculoskeletal, mental health, dementia, cancer, and trying to pull together a strategy for all of the major conditions rather than each of those major conditions having their own 10-year or 5-year strategies. That's the first time that has ever happened in England, and it is the first time that dementia itself has been considered in that way as a major condition. We're not actually sure what that means, so we're engaging with the public consultations and having input into what the major condition strategy might bring for people with dementia and their families. And I know that many people in the dementia field were really pinning their hopes on a 10-year dementia strategy. So we're in a state of flux strategically, but like all strategies, there's always possibilities. So for us, and certainly I feel that the major condition strategy may well raise the profile of dementia that it hasn't had in the past. Like cancer care has had a very high profile, quite rightly, as has cardiovascular disease. Mental health has had a profile, but it really needs uplifting. So I'm hopeful that maybe the major condition strategy may well offer something different in terms of what services people with dementia and their families can expect. There's a huge caveat about that because we don't actually know, because the consultations are still going on, what that looks like. So that's strategically, that's what's going on in England. Scotland too have launched their new dementia strategy. So we've been engaging with finding out about what services could look like for people with dementia and their families in Scotland. On local levels also, Bob, what we're seeing is lots of local areas moving and designing their own new dementia strategies with the new structures like ICBs and ICSs that we have going on across England, particularly. Once those boards and teams become in place, then they are charged to look within their locality at what dementia pathways could look like in maybe a different way, a more integrated way. So we're seeing a lot of flux and change in the structures, not just from national governments, but also from those charged within localities to try and improve dementia care services for families. We also are seeing still just the long tail of COVID out there right across the whole of the UK. We hear all the time from people with dementia and their families that and you've probably seen this yourself actually, Bob, that some of those services that were there, however patchy before COVID, still haven't come back, or if they've come back, they've come back in a slightly different way, or they're
Indeed.
more limited. And that obviously causes quite a lot of stress and upset for families who often see these groups and day facilities as kind of lifelines in their support for the people they love. So there's still quite a bit of work going on to try and bring some of those things back. Our diagnostic services are also equally still struggling,
Yeah.
and haven't really been able to deal with the diagnostic backlogs, which actually will have a big impact on any new medications that are coming down the line. As you know, we've got some new medications that are still in kind of experimental phases, although that they might go through to various different regulatory kind of standards organizations to see if they're effective and effective for people with Alzheimer's disease. So the structures and the sources of support in communities are also, I think, a real challenge for people with dementia and their families at the moment. And so, for example, us at Dementia UK, we've seen an increase in people calling us saying, I can't get a diagnosis, I can't get the support, the respite care is not like it used to, so we're seeing families, I think, really struggling. And I think that's reflective of this, like this changeable pathway that's going on
Yeah.
around them, and all
Yeah.
of the systems not being in place.
And
Um,
Paul, can I just
mm,
maybe pick out there? You mentioned this major conditions consultation that is taking part,
mm.
and just focusing on England for the time being. Were we consultees in that? Have we had an input? And could you tell us what sort of things we were suggesting or recommending?
Yeah, absolutely. We are definitely contributing, both as an organisation, and of course, we've been encouraging lots of our supporters to engage with that consultation, as have many other charities, by the way, which is a really good thing. I suppose what we want are a few things. The first thing is we believe that every family should have access to a specialist dementia nurse, an admiral nurse, if they need it, as and when they need it, because not everything is really straightforward in dementia care. Things can be really complicated, and that's where you need that kind of specialist help. I think what happens, I know it happens in Scotland, Bob, as well, is that there's quite a bit of support, if you get any support at the start. So that initial period post-diagnostic support,
Yeah.
but then we know dementia goes on for quite a few years for a number of people, and actually all of that initial support sort of drops off. And so one of the things we're arguing for is much better post-diagnostic support right across the pathway from
Yeah.
pre-diagnosis to end of life. And of course everybody seems to be focusing on the diagnostic part, but not looking at the wider implications for post-diagnostic support.
Well, I
We're
guess the
also
diagnostic part is so important,
mm,
Paul, because that's the key that unlocks access to so many services.
yeah.
So there is a bit of a bottleneck going on there, I think, across the United Kingdom, and that is a frustration, I'm sure. But I was just interested there in the fact that you were saying that our approach is to have from some pre-diagnosed pre-diagnosis all the way through to post-bereavement.
Mm.
That must be quite a unique offering. I'm not so sure there's many other organisations can offer that, is there?
No, it is quite unique. But then if I look at experiences in my own family and I talk to family carers, there are these points along that pathway, that experience of caring for and living with dementia, where things escalate and get more complicated or get more
Yep.
difficult. And those are the points where we believe specialist nurses can really help. So, for example, we know very often in older people with dementia doesn't come on its own.
Of
There
course
are
not.
often other complicated comorbidities that need a lot of help. And so what you end up with as a carer is like multiple issues to deal with and nobody trying to hold that together for you, which is one of those parts that we think specialist nurses can do. And also, I suppose, right across that, pre-diagnosis to sort of post-bereavement, there are transitions, right? There are transitions in and out of social care, from primary care into secondary care, from secondary care often into acute care, and then out into social care and residential, and those points are really difficult for both the person with dementia and their families. And so that's why we argue, I think, right across the pathway. And I think we're unique. Not everybody needs a specialist abdominal nurse, because sometimes people can feel quite stable and they can carry on with things and get support from lots of other services to help them. But certainly my experience and the experience of hundreds of thousands of carers that we work with is there are these points that need real specialist help and support. And actually no strategy yet has ever engaged on those points.
Yeah, and you made reference there to that immediate post-diagnostic support, which can be very reassuring. But for many families, it's just too early because, as you say, some people live very well with it in the early stage, but it is when things come along where there's a change in circumstances, or indeed when the condition worsens. So it's really reassuring to know that we're with people for that journey. Has there been anything that's come out, Paul? Because I guess that we've been, in many ways, we are Dementia UK, but in reality, we've been kind of Dementia England in a number of ways. But we now have services in Wales and in Scotland. Are there any themes that are emerging across these three nations? And indeed, we're in the process of recruiting into Northern Ireland, I should say that. So there's a four-nation approach. Are there any common threads, and are there any big contrasts that you would shine a light on?
So I think the common thread are two, really: complexity and lack of post-diagnostic support. Those really crucial things that families and people with dementia have to cope with, but the gaps are there. And I was talking to some colleagues of ours in Wales recently, and we've got a growing number of abdominal nursing services, and they're there to really help plug those gaps. I mean, I don't know how you feel about this, Bob, but I generally feel that, as a major condition, as dementia is now classed as within the new major condition strategy, we simply don't have the same level of resource or level of support as some of those other major conditions. There are much clearer pathways in those other conditions, whereas we really struggle and have done for years with that. So I suppose some of the similarities of these gaps. But there are some positive things that different nations do. So in terms of health is devolved in Scotland and in Wales. It's not in Northern Ireland, obviously, because we haven't got a government there at the moment. We hope that will happen soon. But there are some places are much further forward with integrated approaches between health and social care. I've certainly noticed that, and Scotland and Wales, good examples of that. They're not always easy, these integrated approaches between these stakeholders. But I think, though, that that gap that people fall down, they fall down in every nation of the United Kingdom.
So. Yeah. So you've given us a very clear picture of what the current state of play is, Paul, and you mentioned some of the new medications that have come on the market. And I'm just interested to know, from your experience, how do you see that going? Because it's still very early days, but there is a lot of positive talk about it. Typically, how would you see that having an impact on those with a diagnosis of dementia?
Yeah, I suppose so I'm a clinician, and therefore by definition need the evidence and need to know the efficacy, and then also move into the kind of practical considerations. How does it work? Who gets access to them? What are the recommendations? At what stage? And I don't think we know all of that yet to be able to say, right, this is how we're going to design the new service if, as and when these medications come on the market. I should say they're medications for Alzheimer's disease. So, and don't forget, we have lots of other types of dementia to support that don't have this level of research and medical advance. So we don't fully know what it looks like, but our understanding and with working with other partners as well and other charities is if they were to come onto the market now, would need a radical shift in diagnostic processes, and the diagnostic needs to be really early so that for those drugs to have any potential benefit. And I think we also know that potential benefit is all it is,
Yeah.
and it may not work for everybody. So I suppose I'm quite cautious. I really welcome the fact that we're back into biomedical research and trying to look at treatments and cures, because we kind of walked away from it for a few years and that let us behind. But I wouldn't want people with dementia and their families to get kind of caught up just yet, because I think we have to be really sensible, look at the evidence, look at the side effects, and then think about how they're going to work if and where, and if they get approved or whatever, because I think it would take quite a radical shift for us to be able to deliver any kind of new medication, because we've got such a backlog in diagnostics. So I suppose I'm just very cautious, Bob, at this stage, I would say. And I need the evidence, I need the safety data, I need to look at the side effects and the benefits, because the benefits might be really limited, for example.
Yeah, but you do sound cautiously optimistic, Paul, which is pretty encouraging to hear. So what we've done so far in our conversation is we've really talked about the state of the nation and where we are with dementia across the UK. We've had a little glance into the future about what medication might be able to do, and there is clearly a focus on Alzheimer's there. Can I just ask, how would you characterise what Dementia UK is doing right here, right now in 2023? And has that changed?
Yeah, that's a great question, Bob. Thanks for it. Yeah, it's changed. I would say it's changed and transformed. So, we've got changing things going on in relation to the external world that we're working with. And I mentioned these kind of more integrated kind of care pathways that are being developed, and how we then fit into that. I think we've seen higher demand for our delivered services. So we as you know, Bob, we have a national dementia helpline staffed by our Admiral nurses, and we also now have a national clinic service staffed by our Admiral nurses. And we've had to increase the numbers of nurses on the helpline and also open up more and more clinic slots. I don't know whether that's telling us that our services are amazing, because I would say that they are, but it's also telling us that the need is still being unmet out there on the
Absolutely.
ground.
Yes.
So for us, the other challenge we've been doing is trying to grow the number of Admiral nurses right across the board, right across the UK. So we've got more nurses working in acute care, we've got more nurses working in primary care, more nurses facing into other community services than ever before, and we're in a period of growth as a charity. That there's still not enough, right? So if we think about the scale of dementia and the support needed, we're still trying to make sure that we've got enough specialist Admiral nurses for families. We've also been sort of innovating and trying to help people who are often hidden in the wider dementia service provision. So, for example, we've just got in London, across 5 boroughs, we've got a new Chinese-speaking Admiral nurse service, which is tremendous, and we want to do more of that, because there are so many people in our society that are kind of missed off the list, if you like, when it comes to dementia. So whether that's different cultural communities, LGBTQ2 plus, and all those other issues, prisons, we've been doing a lot of work to try and support the growing number of people in prisons, for example, particularly families, supporting that area. So we're trying to widen access as much as we can, and we're going to continue to do that. As a charity, we're growing as well. So when I joined the charity, we had I think around 100 employees. We now have over 200 employees. So, and when you grow as a charity, you have to grow your infrastructure as well to be able to support that the amount of services that we're growing. We've got, you know, we're getting close to that magical 500 Admiral nurse mark, which I'm sure we'll get to well before March next year. And then we're not going to stop there. It's like, you know, how do we keep building on with this, with the increase in specialist nurses? The other thing we're doing, hopefully, is becoming a trusted voice, a trusted clinical voice, if you like, in dementia care. So we've got a new campaigns and public affairs team being established to really help policymakers, politicians, both within all of the devolved nations, but also within the kind of UK government, to make sure that the complex needs of people with dementia and their families are really understood at that level, and hopefully that will infiltrate future policy.
That sounds like the future's bright, Paul. You've covered the growth of our hosted services. You've talked about how we're providing more direct services there in terms of helpline and the clinics. But it's really interesting to be part of an organisation as we emerge into, as you say, the voice of dementia, and we're being seen as being, you know, a really useful resource to the public. So that's encouraging. Paul, we've run out of time. The plan was to talk for just about 15 minutes, and before we know it, that's us into 20 minutes. I would like to thank you very much for taking these questions today, and hopefully the audience now are going to interrogate you just that little bit further. So thank you very much for your time today, Paul.
Thanks, Bob. Enjoyed it. Thanks a lot.